May I request Dr. B K Sudhakar kindly come and join us. Dr. Sharat Chandra, I think you are required here on the stage. Dr. Prashad Reddy.
Welcome to Meitra in Kozhikode, Kerala. And at the outset, our sincere gratitude to Dr. P.C. Rath and his team for this wonderful opportunity. Now today, we have an interesting case. And first I'll introduce my team. Myself, Dr. Ashish, my colleague, Dr. Sajid Yunus. Okay. We have Dr. Nair, Dr. Jomi, okay. Anesthesia support by Dr. Gopal, then Mr. Habish, Ms. Nino, Mr. Srirag, and we also have our technical guy, Nazim Shah from Merrill. We have Afsal and Abarna, plus Aslam, so many of us, and all of us are happy about this and sincere gratitude.
Okay.
So my colleague Dr. Nair will introduce the case details with you.
Okay. Okay, Dr. Kash, please.
And status post PTCA to RCA. He has severe radiculopathy involving the cervical and lumbar area. ECG showed concentric LVH, sinus rhythm, normal PR interval, and normal QRS duration. Echo showed severe aortic stenosis with a valve area of 0.58 and mean gradient of 60. And he has an STS score of 5 and a Euro score 2.5 and a frailty index of 0.41. The valve morphology was not clear on the echo, and hence we went ahead with the CT report. And over to you, sir.
Yeah. See, the CT showed type 0 bicuspid aortic valve. Now the annulus measurement was about 22. The LVOT is slightly smaller than the annulus. Moderate calcification. Next. The coronary heights were adequate. The access sites, the femorals, were good sized, free of significant calcification. Now the procedural planning wise, the transfemoral axis, bicuspid aortic valve calcification is very moderate to severe. Because a smaller sized annulus and the LVOT is slightly smaller, we entertained the possibility of a self-expanding valve, but this was rejected because of religious reasons. His religious beliefs does not permit using a porcine prosthesis. So we had to go for the bovine prosthesis, then right femoral artery access, and generally for these smaller valves, we use only one ProGlide, and if required, an angioseal or an obtura. Next. And because it's a bicuspid valve and the LVOT is slightly smaller, we don't want to cause injury to the LVOT. We decided on a 23 millimeter my valve, which is about 1.9% oversized. And I would like to hear your comments as well, because the LVOT is slightly smaller than the annulus. Next. This is the deployment coplanar view. Next. Now, the two things that we wanted here is basically we are using a 23 millimeter my valve octacore. Now, being bicuspid, the right coronary artery takes off at around between 12 and 1 o'clock positions, and the left coronary artery between 3 and 4. So, to achieve a coronary alignment, we wanted the commissures to be between the two coronary arteries, So the commissures should be at 2, 6, and 10 o'clock positions, which means when we crimp the valve based on the clock position, we will crimp it in such a way that one of the commissures is at 12, and once it goes in, it will, being a mirror image, it will be at 6, which naturally means the other two commissures will be aligned at 2 and 10. And the octa-core, we thought, because again, it has probably the shortest degree of foreshortening, less than 20% as compared to any other valve in the market. So the plan is this: we just have the femoral axis taken and one proglide, and the contralateral femoral and the venous. So any discussion, suggestions?
No, sir. Actually, you can proceed with your plan.
And these
It
days we don't
looks
take a
nice.
pardon.
Because of bicuspid,
Right, thank
you
you,
are
thank you.
selecting this balloon self-expandable valve.
Yeah, and also because the LVOT is slightly smaller, it's relatively smaller annulus.
Okay.
LVOT is smaller than the annulus.
Okay.
So a valve which has a supravalvular positioning will be better, definitely.
Yeah.
But the religious beliefs does not allow that.
Okay, right. Thank you.
So what we have, we don't take injections these days, try to minimize. His creatinine is normal. The creatinine clearance is 75 plus, 75 ml per second, but still, these days we don't, we limit the contrast injections as much as possible. If you have difficulty in crossing the valve only, then we take injections. I can see I think my friend Manik Chopra is there as well. Manik?
Maniki is not there. Sir. Yeah.
Oh, sorry. I thought I saw his name there. So, yeah. So, now do you want to switch to escorts and come back, or? Yeah, so that was not very difficult. Anyhow, we are across. Now that was an AR2 catheter and the 035 straight Teflon wire. And our idea is to actually achieve a 90-10 deployment, if possible. Pigtail.
Sir, you can proceed on your work. We switch over to other center. Okay? We'll come back again.
Please do, because
Okay,
the wire is there. Yeah.
Thank you,
So
Dr.
just give us
Kashyap.
5 minutes and we should be there.
Thank you, Dr.
Yes, thank you. Yeah, so we crossed, and then now we have a safari wire there. Okay, the gradients were about 80 millimeters of mercury. And now we are ready with the pre-dilatation. An 18 millimeter balloon, the smallest dimension of the annulus, and the short axis was about 19 millimeters. So we have an 18 millimeter mammoth, all set to go. And yeah. Yes. Yeah. Srirak. Space. Yeah. And facing. Yeah. Yeah. Yes, go up. Go. Go. Yeah. Go. Yeah. Yeah. Inject. 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 Srirak. Yeah. Deflate. Yeah. Fine. Fine. Off facing. Off facing. Yeah. 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 Yeah, he has behaved well during the pre-dilatation. And the fluoro shows that we are well away from the coronaries.
What is the
Could you
size of
please
this
play that
balloon, sir?
fluoro
Mammoth balloon
save?
size?
Now, that's an 18 millimeter balloon.
18 million. Okay, thank you.
18, yeah, 18. See, because the annulus the elliptical annulus in its short axis is about 19 millimeters, right? And in its long axis is about 25. So the average is about 22 point odd, and that is the reason why we have taken this. Now the valve is ready. There is a bit of an QRS widening. Still in sinus rhythm, PR interval is normal. The pressures are good. ACT?
What is the LVDP, sir? LVDP.
Yeah. The LVEDP was not very elevated. See, the LV function as such is normal.
Okay.
That
Is
was
this
about 12.
Yeah, is this new onset
Right.
LBBB or pre-existing
Pardon? Yeah.
LBBB, sir?
No, this is a new onset. This
New
is just out of the
onset.
pre-dilatation.
So careful. Okay.
There is an LBBB. Yeah, there was no pre-existing. The QRS width was normal.
Narrow
The
QRS,
PR interval was normal. Right. So now we have this 23 millimeter octacore going in. The ACT is 300 plus. Right. And because the Python sheath has been primed with an 18 millimeter dilator, it is not very difficult to take this across. So that was the only shot that we have taken during the balloon dilatation, just to give an idea of how the coronaries are like. Habish, can you push it through? Come, let's push it through. Yeah. Yeah, fine. Ongoing. Gone?
Any difficulties, sir?
Not much, yeah, because the sheath, yeah, that's it, yeah. So sometimes you require a bit more of force to push it through, right? So now that is out, right? See, the axis vessels are pretty good in size, so it's not much of an issue. But then, see, as you get older, your physics also is not great, right? So now we go in, flex. Yeah, not talking. Kabir, Sajid. Yeah. So now with a bit of torque, that was pretty straightforward, right?
This
Yeah,
is
so we are all set.
23 millimeter my valve.
This is a 23 millimeter octacore. Pardon? My valve octacore.
Yeah.
So the octacore is only, as you all know, it is just about 2 rows as octagons. And most importantly, you have those, the fourth marker. That's a broad marker, if you see, the proximal, the mid, and the distal marker. Plus, you have the deployment marker. The greatest advantage of this valve is that the foreshortening is minimal, and if you actually align it at the deployment marker, it gives almost like a 90-10. So we are ready for an injection. This was the deployment angle.
This is the bicuspid
Right,
view?
we'll pace. It is yeah. Now this was the the coplanar view.
Coplanar.
Right, pace it, we are ready, no? Yeah, pace at 140, yeah. Yeah. Inject. Yeah, off pacing. Yeah. So being a bicuspid, probably will come up a little, so that we'll try to achieve almost like a 90-10 or even 95-5 if possible. There is not too much of calcium, so maybe a 90-10 would be safer and probably would be adequate. What are your thoughts on that? back a little back.
Can you see in the other view as well? Probably, I don't know, your RAO caudal is a little bit more, but that is if the coplanar view is fine.
Yeah, yeah. Actually, if we can play the chart, see, even here you can see that, they look, see, you can see the cuts are pretty aligned,
Yeah.
right? Maybe a bit more of a caudalish would be better. But then see, this is, the valve is, the design permits this kind of deployment, and the most conspicuous marker is the deployment marker.
Okay.
So I think we can probably go, right?
Yeah. Your
Okay.
right coronary artery has an abnormal
yeah.
origin also,
See that?
but that's fine.
Yes. But then the sinus is pretty roomy. And as I said, what we have done is we have aligned it in, there is a complete coronary alignment. We expect the commissure to be between 2 and, at 2 o'clock, and the coronaries take off from, the right coronary is about between 12 and 1, and the left coronary is between 3 and 4.
Fair enough.
So with this kind of alignment, we have achieved complete alignment, like even up to 6 degrees in some of our cases. So that is what we are looking at. Okay?
Okay.
So we are ready for the deployment.
Yeah. Please.
Right. Is okay? Yeah. 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 Yes? Yes? You want to go down a little? Yeah. Right? Yeah. Go. Yeah. Go. Okay. Yeah. Go. Yes. I want to come back. Yes. Little back. Yeah. Little more back. Yeah. Yeah. Right? Yeah. Oh. Yes. Not fully. Yes. No. No. Yeah. Go. What is? Off facing. Off facing. Off facing. Off facing. Yeah. Off facing. Yeah. So. Yeah. It's not fully in. Go fast. Get some water fully in. Yeah. Go fast. I don't want issues there. You just. You ready? Yeah. So a bit of front end. Ready? You ready? Yeah. Yeah. Mighty Guru. Yeah, there has some technical issue with the deployment device. Yeah, okay. You're going up again? Yeah. Yeah. You're pacing at 140? Yeah. Yeah. Okay. Go full. Okay. Yeah, deflate. Off pacing. Yeah. Front end. Yeah. Side is on the sheath. Yeah. Right. Yeah. Have you just take it up? Yeah, side is on the sheath on the, yeah. Bit of fluoro. Yeah, so now we would, I think we'd be happy with the positioning. We will just give you the, we are just checking the echo as well. Yeah, just modify the view. And not yet, maybe. Yeah. Right. Yeah. The pressures are fine. The patient is still in sinus rhythm with a bit of that LBBB. Right. And the pressures are fine. Doesn't seem to have too much of an AR, and we'll see. Get me the wire. Yeah. So my colleague is just checking the echo.
Can you see the gradient in between?
Yeah. Do that. Yeah. In between, I'm just trying that. Yeah. Yes. We'll give you the gradient in a minute. So we have the echo, the transthoracic, well-deployed valve. There doesn't seem to be any PVL as such. No. Maybe there's a, a central AR which should be wire related. Check the echo gradients. Oh, if we could focus on that, there's hardly any gradient on the echo.
Yeah. But
Huh?
yeah,
see that?
the upper tracing, upper pulse Doppler, continuous wave Doppler is a AI signal or just?
Yeah, could be. I mean, as I said, no, there is a bit of an AI probably wire induced because it doesn't seem to be paravalvular on the color Doppler.
Just change the scale and like color, it is not.
Yeah. Yeah, see that? You can zoom it, yeah. It's only mitral flow on the other side, not much. Anyhow, we'll get an injection and see. Right? Right? Srirak? Ready for the injection? Srirak? Srirak? Yeah. Right? Srirak? Ready? Injection? See,
Great. I think.
now there doesn't seem to be, there doesn't seem to be any PVL.
Yeah, just grade 1 maybe. Less
Just a
than
bit of,
that.
yeah. Exactly, exactly. And probably we can give a better picture as well. See, if you look at it, it is 90-10 on this side. Positioning also, you would agree, well away from the coronaries.
Yeah, coronaries are fine.
Fine. Yeah. So now we'll check the hemodynamic gradients as well.
Ashish, what was the
And because of the
diastolic pressure at the
bicuspid,
beginning? Just
Pardon?
what was the diastolic
the
blood
diastolic.
pressure, aortic diastolic in the beginning?
Yeah, the diastolic blood pressure was about 50-ish.
Yeah. So that's fine. Its pulse pressure usually at this age is a little bit that.
Yeah, exactly, yeah. Because he is in his 70s.
So with your permission, we'll be going to the other lab, Ashish. And I think you have done already
what
a
we can do
wonderful
is,
job.
See, now, if you could just, this is Dr. Sunib, is it?
Yeah.
Is it Dr. Banerjee?
Yes.
Yeah, Sunib. See, it's wonderful to hear from you. Now, we will just show you the gradients, the hemodynamic gradients on this side.
Show it, please.
Right? Just be with us for a couple of minutes. And, hello?
Yeah, with that.
Sunib? Yeah, see.
That's great.
Pseudo gradient. The diastolic pressure is 62. Right? And if you come back to us, see what we can show is probably we will get a Dyna CT just to show how the coronaries look like after a coronary alignment. Sometimes we get great pictures. Anyhow, we'll try it out. So if you could come back to us in 10 minutes, we'll be ready with probably a Dyna CT and closure.
Thank you.
Thank you, Dr. Kashyap.
Okay?
We are with you. Please show the final result. And
Yeah. Okay. Actually, my name is Ashish.
Ashish,
Sorry.
okay, sorry.
Yeah. See, the thing is, actually, we have done. See, because we can show you the, there was absolutely no gradient. And the previous injection, the previous one. Okay?
Yeah.
Now, there is trivial to mild a leak. You can see the LV filling up just a little. Now the commissions are well away. We got a Dyna CT done next. Now the Dyna CT tells us that actually the coronaries are way off the commissures. You can make out the commissures. Sometimes if you get a cross-sectional view, you get to see the coronaries. But because so sometimes the valve gives so much of dense radio opacity that it is difficult to see the coronaries in cross-section. And here that is the case, but you can make out the coronaries are off the commissures. You can make out the three commissures as well as the gantry rotates. Next. So gently it has been our practice to actually, reverse heparin, partly. Next, yeah. And this was just one proglide, nothing else at 12 o'clock, and that is the groin.
Great.
So there is a bit of a left bundle, that left bundle branch block is persisting. Sinus rhythm is normal. You can see the groin over here as well. And so what we do is we keep the temporary in for about few hours, 4 to 6 hours, make sure it's not worsening. And if that is the case, we remove the temporary. Would that be appropriate?
Yeah,
Your
yeah.
thoughts?
Yeah, it is appropriate. Very nice
Okay.
result. Yeah.
So now that was wonderful. Thank you for giving us this opportunity. From all of us, the team here, my colleagues, Dr. Sajid,
Yes.
Habish, Dr. Nair, Jomi, everyone in the cath lab. Okay? A big thank you.
Thank you. Nice demonstration.
And hope you have a wonderful evening tonight.
Evening. Thank you. Thank you.
Thank you. Thank you. Thank you. Bye. Thank you. Thank you. Thank you.